Please find your seat. The program will begin shortly. Please take your seats. The program will begin momentarily. The program is about to begin.
All right. Hello, everyone, and welcome to Glucose Biosensing for All. I think it is one of the most action-oriented panels we're going to have this week, and there have been some amazing panels. This is great. We're going to start by the following. I'll introduce myself with some really great music. And I will tell you a little bit about our panelists. Then I'm going to have each of them both introduce themselves and give a little lay of the land where we're going. And then we'll do a little conversation, but we're really going to save time for a conversation with all of you so that we can interact together. My only request, I'll make it up front, to our panelists, we've discussed this, but also to you, is if we try not to do monologues, but to really keep things back and forth, quick, short, concise, I think we'll get through so much more because there's a ton to talk about in the next 50 minutes. So I'm Dr. Ami Bhatt. I'm a cardiologist by training up in the Boston area. I'm now the Chief Innovation Officer at the American College of Cardiology. And the reason I am sitting here is that we have gone from being tertiary focused in cardiovascular care to then thinking about outpatient care and reaching into communities to now recognizing that if we don't give the power to the patient to think about what the risk factors are and start intervening on them before disease, we're always going to have disease to treat, and our goal is to put ourselves out of a job someday. And so with that in mind, I get to be here with these two lovely people. And so Jessie Inchaspe is known as the Glucose Goddess.
Good job on my last name.
Thank you. She is a biochemist by training, also a famous author. So very excited to have her with us. She also wears a flower, the best of anybody I've ever seen. And Jake Leach also wears checkers very well, no flower there. And is the CEO of Dexcom. So really happy to have them here today. We're going to start by talking about what do we mean by glucose biosensing for all. Then we'll talk a little bit about patient agency and what that really looks like rather than as a word, as an action. We'll talk a little bit about equity to make sure that everybody has access to doing this because we know that the largest risk populations are those who cannot go out and necessarily avail themselves of the most advanced technologies. And then we will end with policy. For that, I will give you my only disclaimer. I'm the chair of the FDA's Digital Health Advisory Committee. We set AI governance for the country. I'm not representing the US government in this room today. With that, Jessie, will you start by telling us just a little bit more about yourself, if you'd like? And then will you talk to us about what we mean when we say glucose sensing for all, because we're not talking about diabetes and cardiovascular disease only.
Of course, thank you, Ami. Okay, first things first, let's start about what glucose is. So this is going to be an interactive little section. Can everybody go like this? Yes, good job. Okay, so when you do this, your muscles are contracting and they're burning glucose to contract. And right now, your brains, your hearts, your livers, every cell in your body is using glucose to perform its function. So glucose is really the molecule of life. And we give it to our bodies by eating carbohydrates. Now, a little bit of carbs, super, a little bit of glucose, great. But if we give our body too much glucose, problems start happening. I kind of like to take the example of a plant at home. Do you have any plants at home, Ami? Mm-hmm. Yeah. So a little bit of water in the plant, everything goes great. Too much water, the plant drowns. So I know, same. Yeah. Like, no way. And so for many of us today, I speak particularly to people who do not have diabetes, we are still in a situation where we're giving our body a bit too much glucose, and this can lead to symptoms. And so my own personal story and the reason I got passionate about glucose is because when I was 19 years old, I broke my back jumping off a waterfall. don't jump off waterfalls. Tell your kids to not jump off waterfalls. And I had very intense surgery, physical pain for many years, but also a lot of psychological issues arose from this incident. And nothing helped me for almost 10 years until, completely randomly, working in Silicon Valley, I had the opportunity to try a glucose sensor. And I saw, as a person without diabetes, that I could trigger episodes of depersonalization, which was the issue I was struggling with mentally, with big glucose spikes. There are no studies on this. This is my own personal experience, but I became fascinated with this molecule and tried to understand how to keep my glucose steady without giving up pasta and cookies.
Yeah.
And this led me down the path of today. My work is centered around making the science of glucose accessible, interesting, fun. I like to say sexy, because I think blood sugar deserves more space. And so I share science-backed tips and hacks through my books and my content. And I'm also a proud ambassador of Stello, which I believe is the best glucose biosensor ever. So with that, that's a little bit of intro.
I love it. And you introed Jake just perfectly. Jake is more than just a glucose biosensor, though. Dexcom does a lot. Will you tell us a little bit about you and Dexcom?
Sure. So first off, it's a pleasure to be here with all of you. And as Ami mentioned, I'm the CEO of Dexcom. I joined Dexcom 22 years ago when it was a little startup company. And the company was really founded around this idea of replacing finger stick. You guys know, have you ever seen someone poke their finger, take a blood measurement? It's episodic, it's cumbersome, slightly barbaric. So the idea was, let's figure out a better way to help people with type 1 diabetes manage glucose. And so we developed these small wearable patches. And what's happened over time is, as the technology's gotten more accurate, more reliable, easier to use, and lower cost, we've seen CGM now being used, continuous glucose biosensing, used across a full spectrum of diabetes, type 1, type 2, all the different stages of type 2, pre-diabetes, and then even beyond into general metabolic health. And I think what we've really learned over this course of time is that glucose is a very important biomarker. We all have glucose. Every single person in this room has glucose, and it changes based on activity levels, what you're eating, as Stephanie mentioned. And it is a fundamental biomarker for preventative healthcare. And our goal is to continue to raise awareness for just how powerful glucose is and what we can do to prevent the progression of disease by paying more attention to what's largely been overlooked for many, many years.
So let's just take that for a minute and let's go back to, I like this moving your fingers, burning glucose thing. So I'm going to use it for a second. Could you, if you wear a wearable, could you raise your hand if you wear a wearable in this room? And you can look around to see how many other people do. Okay, perfect. If you have worn a continuous glucose monitor ever, will you raise your hand? Oh, this is a good room. Okay, so for most people, and maybe Aspen's not the right place, if you ask, you will find that a lot of people will wear something that feels like a wearable, and the majority will not have tried to measure their glucose. As this is changing, we start to ask why. And one is, yes, when you have clinicians prescribe it for you, that is kind of a academic gateway, if you will, right? Or clinical gateway to, you should wear this, and then people wear it. The other is when patients say, hey, I'm kind of curious as to what's happening. I know that sometimes when I'm really low on sugar, I don't feel great. I know that sometimes when I have a ton of carbs, all of a sudden, like, I feel different. What is going on with my body? And the one thing I will say is I think it's a direct relationship, because if we wear our wearables, you're often saying, did I sleep well or not? You know, what does my HRV do? Why is HRV so popular compared to glucose? Actually, glucose is easier to understand than HRV, just note to self, right? And so I guess I'm going to ask for data, because enough people raise their hand out here. Do we have data that measuring your glucose is making patients actually make changes? And what does that data look like? And not just in those who maybe are at the type 1 or advanced type 2 cardiovascular disease diabetes, kind of earlier in that journey. And Jake, I guess you want to start maybe.
Yeah, absolutely. So one of the things that Dexcom's done over time is create a significant amount of clinical evidence that shows the benefits of CGM. And we started in type 1 and we've worked our way through the entire spectrum. But just to put some numbers on it, if you look at the United States population, there's 40 million people living with diabetes in the US. there are 115 million people living with prediabetes. So basically already progressed to dysglycemia and likely going to progress to diabetes over time if changes aren't made. That 115 million, I mean, is more than the number of people watching the World Cup right now. I mean, it's a very substantial number. It's 40% of our adult population. So,
and Jake, worldwide, it's like 1 billion people have type 2 or prediabetes, right?
yes,
Yeah.
more than 1 billion people around the globe have either diabetes or prediabetes. And so it is a significant strain on the healthcare system worldwide. In the United States, 1 in 4 healthcare dollars of our $5 trillion is spent on treating diabetes. So as you look at what CGM can do for people, it really helps you understand how different parts of your life impact and different behaviors impact your glucose. And one of the things that is really eye-opening for people is when they wear a glucose biosensor for the first time, they see just how much glucose changes throughout the day. I think historically folks have thought, yeah, my glucose levels run high, but they actually move around a lot based on activity level. Even just basic walking substantially reduces glucose. And so as we look at what happens when someone starts wearing a glucose biosensor is they start making changes on their own. We did a study 20 years ago in diabetes, and we basically put CGMs on users, and we blinded them. We did not let them see the glucose information. And so they wore it for a week, and we got these baseline glucose dynamics on these patients. And then for the next week, we turned the display on. And just in a matter of a day or two, their glucose control increased dramatically because of the real-time feedback. Glucose is very unique in that it gives you feedback in real time. You eat something, 10, 15 minutes later, it's going to start showing up in your glucose if there's carbohydrates in there. And so it is a very powerful tool to elicit behavior change and really empower a patient to make the changes to help lower those glucose spikes.
Yeah, it's such a great marker, as you say, because it changes instantly. So if you tell somebody, okay, tomorrow morning for breakfast, try to have something that's protein rich instead of something that's high in carbs and sugar, and you compare the spike of the first day versus the second day, it's a different world. So glucose doesn't take weeks and months to show an impact. Like, it's real time. And I think with the biosensors, personally, what I see in my community is that real time feedback, I would even say it keeps you motivated and accountable because you're seeing what's going on inside your body. So your body's showing you the impact of what you're eating on its internal state. And so for me, when I first put a biosensor on, I felt like I can finally communicate with my body. And so it's so incredible. And that's why it's so powerful when people try it, I think.
I want to take that one step further. It sounds like I make everything clinical, because I guess I do. But if you think about the downstream cost of diabetes to an individual, right, the morbidity of living with that disease, having to constantly manage it, following multiple end organs, eyes, heart, stroke risk, kidney risk, leading feeder for dialysis, right? So all of these things, incredibly important. But let's move up a little bit. Just thinking about, as you get older, cardiovascular disease risk, cancer risk. We had a great cancer panel just before here over in the other pavilion. Glucose homeostasis is really important, but your and my levels both move up and down and are absolutely not the same. I can give you a number and say, in general, your number should be yes and 100 while fasting. We don't really know for you. And so what I love about this is long term, you start to wear these and you get a sense of, who am I? What is my baseline? Where should I be? And then you can also bring that back to the conversation with caregivers or others, not just work on it yourself and say, here's where I lie. This is what I'm looking at. This is actual data based on me and not just a textbook. And I think that's incredibly important for long-term care. The second is, if we look at you during a lifetime, your glucose metabolism is going to change.
Oh, yeah.
So, the way I was when I was 20, I'm not 20 anymore, it's very different than the way I use glucose now. But can you start to see trends that are changing? Can you see trends through pregnancy rather than that one horrible oral glucose tolerance test with the green or orange liquid that's just, right? And if you see things there, does that help you tell you about what you're going to be in the future and how to manage it? And so I think all of that comes from the agency that you just talked about.
Can I jump in?
Yes.
You talked about pregnancy, but also menopause is a big moment where glucose levels shift for women because of the change in hormones. Your baseline gets higher, your spikes get higher, even if you eat the exact same diet as before. And so that's a moment where I really think it's important for females to have access to this tool to see that if they put in place a few specific easy shifts in their diet, they can really help their glucose levels reduce, which also can help with cravings, with energy, with sleep, with so many things. So for me, glucose is like a perfect window through which you can start to change your relationship to food and to your body.
Absolutely.
Anyway, I'm passionate. as
No,
you can
no. So
imagine.
before we go to the equity conversation, I want to deep dive this for 1 second because I saw a lot of nods. I want to talk about how you feel with glucose in your body. I have 2 teenage daughters, so if all 3 of us measured our glucose and we could predict when the other one is going to be not nice, right? Like, just imagine my household, right? So,
wait, do you know about this amazing study?
No, this is what I want to hear.
This is my
I'm here
favorite
for
study
this.
ever done on glucose. It's insane. So these American scientists, they recruited 200 couples, man and women, husband and wife. Do you know about the study? Oh my God, okay. So they gave each person in the couple a voodoo doll representing their spouse. So every husband got a voodoo doll representing the wife, every wife got a voodoo doll representing the husband. And the researchers asked the participants to put a pin in the voodoo doll every time their partner irritated them for 6 weeks. Then they counted the pins and they measured these people's average glucose levels, variation in baseline. They saw, of course, it's an associative study, but they saw that those with the highest fluctuations and the most amount of lows in their glucose levels had put most pins in the voodoo doll.
There it is.
And now if you look at it mechanistically, we understand that glucose impacts tyrosine, a molecule in your brain that has to do with mood. So I think we really need to teach glucose hacks as soon as you get married. It's very important.
Explains it all.
Explains it all. And so that's for, it can be irritability. For others, it can be simply feeling extremely, extremely tired. It can be cravings. It can be brain fog. I mean, the list is very long, and each person will have a different response depending on their specific medical situation. But that study is fascinating.
I am so excited that you shared that. I'm going to go share it with the girls at home. We can do the mother, teenage daughter version of it. I'm not giving them needles and a voodoo doll of me. I don't want to. Let's turn a little bit to where the need is the greatest then. And Jake, I'm looking at you to start for this one. Access to continuous glucose monitoring. Can we get some data from your perspective and from Dexcom's perspective on, are we reaching the people who need it the most? Are we reaching the communities? There was a great word earlier today. Monica Bertinoli, who's going to be the new incoming president of the National Academy of Medicine, she actually referred to it not as inner city healthcare, and she didn't refer to it as rural healthcare. She said we just need to call it community healthcare, and I love that, right? So for average community healthcare, is there access right now, or are we having an Aspen conversation?
It's such a good and important question, and it has evolved quite a bit over time. One of the things that Dexcom pioneered was the over-the-counter glucose sensor. So for many, many years, CGM biosensors were a prescription device, and so it put a good amount of barrier to getting a CGM. And if you had diagnosed diabetes and you were taking insulin, you had coverage, you could get one. But there were so many more people that could benefit from this technology. I mentioned that 115 million people, adults in the U.S. that have prediabetes. 80% of that group don't know about it. They don't know they have prediabetes. An over-the-counter CGM is a perfect way for someone to become more familiar with their glucose health and better understand. But kind of shifting back to insurance coverage for CGM, it started, early days was cash pay completely, and then it turned into coverage for type 1 diabetes, and then type 2 users who were taking multiple shots of insulin per day. And let me just explain this. Basically, these folks' diabetes had progressed to the point where they needed to take insulin, and only then do they get access to a glucose sensor that could have helped them avoid that progression. And so it's something we're working very hard on, is generating all that evidence that shows the impact. And we just did a very large study that read out about a month ago that showed anyone with diabetes has significant benefit using a CGM, particularly those that use GLP-1s, SGLT2s, because those medications help lower glucose, but the CGM helps you better understand the quality of your diet and the way that it's impacting your glucose. You combine something like a GLP-1 or an SGLT2 or insulin with that knowledge around food and activity, it is a very powerful combination. And so we showed that in these studies. And so right now, Medicare, for example, in the United States covers CGM for anybody that uses insulin, type 1 or type 2, even if you use a long-acting. But they don't cover it for 25 million Americans that could benefit, that have diabetes. And we've generated the evidence. We're on the cusp of a potential coverage decision here. So there's still lots to do within diabetes, but there's this significant opportunity to slow the progression or even reverse or stop that progression. And so with CGM, we can bend that health curve. It's just raising the awareness is a big part of this.
It's interesting when we talk about finding out that you might have an issue earlier, right? That's really all we want to do, is we want to get a sense that we might have something wrong earlier. We are all battling across kind of endocrine, cardiology, cancer, the same system right now of how much data do we need to provide and show, and how many randomized controlled trials, which by the way take like 5 to 7 years, and we know how fast the actual technology is changing. We had this just happen in cardiology, which is why I bring it up. You can now get a CAT scan of your coronary arteries with AI that just tells you, do I have plaque or not? It's not a calcium score. It's just a straight up CAT scan. And God, that would be great, because then I wouldn't tell you your risk score says that at 10 years you have a 30% risk of, and by then you're all half asleep, right? Or you're like looking at your phone, figure out when you're gonna like get groceries. And if I could just say you have disease or you don't, you'd want that. And that's really what we're talking about, is chronic glucose monitoring is not as much a trend towards something, which is a lot of what we talk about with our current wearables. It is, you have a glucose that is blank, right? And so I think that's the diabetes side. But I want to move back towards prediabetes for a moment. Your experience, you've talked to so many people, you have gone out there and kind of been in this environment. Will you talk a little bit about how far are we from getting this kind of understanding to the communities who maybe also don't trust healthcare as much? So can you address kind of the trust side of getting CGM earlier, before disease, and are there pathways that don't involve going through someone like me?
Well, when I first started almost 10 years ago, it was a very different landscape, right? So I was living in California, but I could not get a biosensor in California. I had to go back to France and, bring 10 back in my suitcase. And today we have over-the-counter glucose biosensors, Stelo. So that barrier, I think, has been just knocked right open, which is amazing. In terms of the trust, honestly, I don't, from my very narrow perspective, I don't see such a big trust issue.
Good.
I sometimes see a fear issue. And if we're talking about the fact that 80% of people with prediabetes don't know that, there is a segment of that population that doesn't want to know. And so I think it's so revealing when you see all of a sudden your glucose levels. And we have to be mindful of the fact that people, even if you don't go through a doctor, people still need to have information so they don't feel alone when they see something on the biosensor. So to me, it's more that. And then I think the invasive nature of the device, the fact that it goes under your skin, is still a barrier. And people still think it's a needle that stays under your skin. It's not, it's a little flexible little fiber. So we're getting there. And we were speaking offline yesterday and you were asking me, why aren't more people wearing a biosensor? And I said, but compared to 5-7 years ago, so many more people are. So I think it's just, the tide is continuing to grow, the movement is continuing to grow. So again, from my perspective, not a trust issue, I would say a fear and education issue. But what's also cool is that people can feel the difference when they improve their glucose spikes and their glucose levels, even if they don't wear a biosensor. And so for all of us, all of those living in countries where they don't have access to over-the-counter biosensors, I have millions of readers who've felt better and who've seen their fasting glucose annually improve even without a biosensor. So I think we have so much work to do on so many levels, so many channels, so many communities, but to me it's a very positive trend, and it's just continuing to grow.
I just want to say that again. People have seen their fasting glucose levels improve by not wearing a biosensor, but just listening to their bodies. That is what you said.
By implementing some of the science-backed tools that I share that are very simple. Have a savory breakfast, veggies at the beginning of a meal, walking after eating, all of these little hacks. I call them hacks. So yes, you can see an improvement, but when you wear a biosensor in combination, then the impact is so much greater.
I love this. Let's think a little bit about how we are going to now get, oh no, let's not do that. Let's give you a challenging question. You guys okay with that? Okay. Let's say we don't want to put something that's a flexible thing into our arm. How far are we, Jake, from something like this using photoplethysmography like it uses for blood pressure or, radio frequency and getting a number or an estimate or something? Can we do it non-invasively soon?
A lot of research and a lot of investment has been put into trying to sense glucose non-invasively. And if you think about it, we have pulse oximetry technology where you go in the hospital. And when you see something like that, you think, gosh, we should be able to measure glucose that way. And the reality is, though, the physics get in the way of glucose as a colorless molecule. When you do things like shine different infrared light or radio frequency technologies, the reflections from a glucose molecule look very similar to other molecules, so very hard to resolve. Our sensors are under the skin. It's a little sensor probe. It's in intimate contact with the glucose. That's why we can measure it so accurately and reliably. We follow the development of non-invasive technologies very closely. We've made some investments. What we've really come to see is that the likely outcome of the work that's going there is going to be helping us better identify risk levels. So by wearing one of these wearables that they don't do it today, but maybe at some point in the future, could suggest that you might be at higher risk for high glucose levels. You should go pay more attention, get checked, wear a CGM, better understand where your levels are at. And so the non-invasive technology, I'm never going to say never. I'm an engineer by training, but it is very far off, if ever.
Okay. But I do hear from you that potentially the way we can now do blood pressure trending, right? Yeah. Your device says you may have high blood pressure. Please go actually get a monitor, see someone, and check it.
That's right.
Perhaps that will be the first thing that will come long before an actual number might or might not come.
That's right.
Okay. We're almost at time to open it up for questions. Can I ask you, Jesse, and I heard you start this, like 3 glucose hacks that people here can all go out and start using right now?
Okay. So it's 12, right? So you're going to have lunch. So, yes. Right before lunch. Somebody's hungry. So when you're faced with a lunch or a dinner, science shows us that if we eat the vegetables during the meal at the beginning of the meal and the carbs at the end of the meal, we can reduce the glucose spike of that meal by up to 75% without changing anything about what we're eating or how much we're eating. So you don't have to do this all the time. The point is not to, open up a sandwich and have the salad first and the bread last, but if you can keep that a little bit in mind and have a little bit of vegetables at the beginning and keep the dessert for the end, which is obvious, but also maybe keep the bread for the end instead of going for the bread at the beginning of the meal, that can be super helpful. So veggies first and carbs last is a really powerful hack. And then my favorite one, which is hard for some people, but so powerful, is protein for breakfast. I mean, that's the best way to keep your glucose levels steady throughout the whole day. I was brought up being told that breakfast is the most important meal of the day. It's actually, from my perspective, the most powerful meal of the day, especially for your blood sugar. And then last one, this may sound like an Instagram gimmick. It's not. Vinegar. 1 tablespoon of vinegar in a big glass of water can reduce the glucose spike of carbs you're about to eat by 30%. Because vinegar contains acetic acid, which slows down the breakdown of carbs into glucose in your digestive system. So there you go.
The power of suggestion is so strong. So we had a pre-meeting yesterday. This morning, I had no carbs for breakfast. No, it's really strong.
What did you have?
I had scrambled eggs. I had, what did I have with my scrambled eggs?
That's good enough.
I had avocado.
Nice.
which is a healthy fat. Okay, so we're okay. And then I realized after that the green juice I got was probably just pure sugar. So I have to be
One
honest
step
on
at a
stage.
time. But if you had the green juice after the eggs, that's already helpful.
I had the green juice after the eggs. Done.
Good
okay,
job.
sold.
Good job.
Jake, 3 things that you want this audience to know about the future of where kind of glucose sensing and glucose management is going from an engineer's brain.
Yeah, I think, well, first off, it's quite simple. We all need to be more aware of our glucose. Everybody, each one of you got a Stelo biosensor in your bag. I encourage you to take that and use it. Learn more about your numbers, more about your patterns. Glucose is a very preventative marker when it comes to health, and I really think, as we've talked about throughout this panel, there's plenty of ways for us to easily manage it. It's a very empowering technology. As we progress into the future, there's already millions of people that use CGM today, glucose biosensing technologies. It's still only 2% of the world's population that has diabetes, and that's before we talk about prediabetes. So there is a very long way to go in raising the awareness of this technology, the benefits it can have, and the access. From a technology perspective, it's going to continue to get easier to use. We're going to start integrating other health data and turning complex data streams into very actionable insights for users. It's actually what we've seen in our over-the-counter product. We've put more insights in there to help people, guide them on their health journey, not just the glucose data. And it is really showing an impact in people's ability to lower their average glucose levels just by making some of the changes that we're suggesting through the software.
I love this. All right, we have 19 minutes and 30 seconds for questions. I do want to point out that none of us used the word AI in this panel. Okay, now you can ask questions about it. It's fine.
Yes.
Do we have a mic that'll go around? Yeah, feel free. I'll let you pick and move around.
Hi, I just wanted to ask about glucose biosensing for all.
Sorry, could you stand up and could you tell us who you are so we can all meet you?
Hi, I'm Shayna. I work with T1 International, and I wanted to ask about access for glucose biosensing for all, particularly in the global south, and for folks like with type 1 diabetes like me. And I know in Egypt, they just announced a presidential initiative to get continuous glucose monitors for children with type 1. And yeah, just wondering if there was more being done, and just could share a little bit about biosensing in the global south.
Yes, of course. It is, as we think about the benefit this technology can have, we look at it from the most acute perspective, which is type 1 diabetes, children with type 1. It is a very powerful technology for them to extend their life and better manage disease. And so as we have worked on the technology, we've brought the cost down fairly substantially, but we still know that $90 a month is still unreachable for many parts of the world. And so working through how do we continue to make sensors last longer, make the technology even more reliable, even lower cost, that is a big part of the future where we're going. But in the interim, there's plenty we can do in terms of access to the technologies. One of the things we've done is in Eastern Europe, there was no coverage for CGM. A number of years ago, we started introducing a low-cost cash pay version. And when the government started seeing the impact that that technology was having in their population, they started moving more healthcare dollars towards it, because they know in the long run, there is a government insurance. They're going to be taking care of these folks for a very long time if they can help them live healthier and reduce those costs. So they jumped right on it. And that is generally what we see with payers across the world, is once they start understanding the health benefits, but when it comes to coverage, it's also about the economic benefits. When they see those economic benefits, they move pretty quickly, and that's why in the US we're seeing coverage for type 2 diabetes, not on insulin, moving very quickly in private insurance. And so lots more to do around the world. Half of the world's population that has diabetes lives in the Asia Pacific region.
Yes.
That's one of our smallest markets, and so we really want to expand both the technology and access to it around the world.
For those who are working in that space, I will just say one of the things we're thinking about is we are going there now and working with ministries of health throughout kind of Asia Pacific and the African subcontinent for earlier cardiovascular diagnosis assessment. We haven't brought CGMs with us. So I will think about it, but if any of you are doing that, just remember to kind of also work with the infrastructure that probably already exists, because I think there's an opportunity. Next question. I'm letting you pick. You're in charge, Elsa. You do both sides? Okay.
My Thanks so much. I'm wondering, Dr. Bott, as a cardiologist, how do you think about guidelines? You know, glycemic health guidelines, people understanding where they are and where they can go, and maybe how your peers feel about it.
Yeah, thank you. So guidelines are our middle name. Like I really go around by Ami Guideline Bot. You have to sign that off when you become a cardiologist. However, they exist for a reason, and they exist to make sure that the majority of people who are cardiovascular disease patients, let's even talk about prevention, potential cardiovascular disease patients, are offered the right kind of screening to be able to catch them early. The problem with guidelines is those guidelines are given to clinicians, of which we don't have enough, because our workforce is far lower than the number of patients that they reach, and a lot of people just don't have access to those clinicians, nor do those clinicians have the time to read every guideline for every field. It's not just cardiologists, there's primary care doctors who are really our first line for cardiology, and they don't have the time for that. And therefore, I sit here with my colleagues thinking, we need to go straight to the patient. One of the things we're working on, see now I'm bringing in AI, you made me do it, is really we're working with open evidence, we're working with some of the other large language model providers. Abridge is one that does voice to text technology. And we're seeing, is there a way to get patient-oriented information that medical societies approve into the hands of the general population? And so I kind of feel like Dexcom in Asia Pacific, it's very small right now, the number of people that we, a clinical organization, are reaching directly as patients. But I think that pathway of health literacy not being this awkward thing that people just study, but something that we do is really important. I think marketing's important. There are really large budgets out there in pharma and technology. What if instead of marketing the drug, we said you need to have an educational marketing budget direct to patient? Don't talk about your drug. Don't put your drug's name on there. Just teach, right? And maybe that will help. Although what you said, Jesse, made me nervous.
Which one?
If people have fear about finding out they have something, we probably need to create education that also helps hold their hand.
Yeah.
In wanting to know whether their glucose is out of range. And I don't know about that part of the education. I don't think the clinicians are there yet. I don't know if you have thoughts on patient education from your perspective.
I don't have an answer. I think maybe educating on the fact that even if you do have a prediabetes diagnosis, it is not a life sentence. Like you can do many things about it.
That's right.
And so showing, because a lot of people also still think, and I see this in my community mostly, that if you do get type 2 diabetes, you'll have it for your whole life. It's still not clear to people that type 2 diabetes in most cases can be put into remission or reversed depending on how you want to talk about it. So if you show that, I think the fear goes away a little bit.
I think that's the key is, there's the maybe fear of understanding the diagnosis, but then helping anyone who has that diagnosis understand that something like CGM is such a powerful tool that it can empower you to actually make changes and reverse. I have countless stories of people who've reversed their type 2 diabetes or their pre-diabetes diagnosis by making lifestyle changes to the point where many of them aren't even on medication anymore. Mm-hmm. They're still at risk for diabetes. They still have to pay attention. They still have to watch what they eat and their activity levels. But it's a reality. You can make a significant improvement in diabetes diagnosis, pre-diabetes, in general health just by paying attention to the numbers.
And the earlier you start, the easier it is.
Yes.
That's right.
So as we go to the next person, bring a mic over, my short answer to you is cardiologists like me recognize that we can't manage population health without empowering the patient. And so guidelines could become a bottleneck if we had everything dependent only on guidelines.
I mean, I was just thinking,
right?
everyone just test.
Yes.
Just get a profile. That's part of the guideline to know where you are in your glycemic health.
Yeah,
So
yeah.
And there are many therapies that have gone generic, that are going generic,
Yeah,
that would be
yeah.
indicated for reducing cardiovascular risk and have a side effect of preventing T2D or pre-T2D.
Yeah, yeah. No, I think screening is everything. I will say if you put it in a guideline, doctors get worried that now I'm responsible for that, and it's not the doctor's fault. They have 15 minutes with a patient. That doctor wants you to get everything and wants to spend an hour and a half with you. They don't have an hour and a half nowadays, and I think that's the system is the problem, not the clinician not wanting to do it. Do you want to go up
Yes,
here
hi.
and then up here?
Yeah, fascinating discussion. My name is Jyoti Pathak from Arizona State University. I have a question for you, Jake, about your multimodal data piece that you brought up. So an average family medicine provider, primary care provider, are already drowning with Epic and data that they have already access to. This is yet another stream of information that many providers don't want to know, don't know what to do with it, and it's a big challenge. So I'm curious what you are, as an organization, trying to deal with that issue.
A couple of points there. I think when you look at the patient empowerment, most of the improvement here comes from patient behavior. In most of our studies, when we run them, there isn't a lot of clinician intervention. There is some work to optimize glucose-lowering medication doses, but the vast majority of the improvement comes from the patient's changes in their behavior. And really, there's learnings, right? Much of this has been invisible for so many years. People have been told, hey, your glucose levels run high. Here's another medication to try and lower it. But they've never actually seen their glucose in real time. So a big part of it is just empowering the patient. It's less on the provider. But one of the things about providers that this data can be really helpful with is helping them understand the level of risk in their patient population and who needs the most attention. And so we've been working on clinical dashboards that will be integrated into Epic that help them look at their patient population that are using CGM and help them understand these are the folks that are at highest risk that you need to get to first. And often what it means getting to them is talking through their therapies, what are they working with, what drugs are they taking their medication, are they using their CGM, and it really can have a significant impact. Our goal is never to increase the burden on either the patient or the prescriber. It's about reducing that burden. Sometimes technology does add burden, but we're quickly working to remove all that friction to make sure that this is a technology that can be used by hundreds of millions of people.
Hi, Andrew McConnell with The Lively. I wanted to kind of build on that question to even go earlier, so not just pre-diabetic, but this is a room of pretty educated people, and Jesse had to give us tips on how to change how we eat. And thinking back to what Dr. Alexander was sharing yesterday on how games can teach us, is the opportunity for a wearable that's not super precise, but that children way earlier could start learning proper nutrition habits, so we're not having to relearn or unlearn things in our 30s and 40s and 50s. Wouldn't that be a bigger opportunity than once people are already pre-diabetic?
Couldn't agree more. Going after the preventative component there and looking at nutrition, which is a big part of why we have this challenge with prediabetes and diabetes as we grow older. And the three main causes are diet, sedentary lifestyle, and aging population. Those are the three drivers of diabetes in this country and what is making it become such a serious issue. I think building some sort of dopamine loop that's in this idea of engaging users. One of the things I talk to my team about a lot is just user engagement. What else can we do to get users engaged with their health? The real-time data the glucose data is very engaging for many people, but there are still people that look at it and say, well, what should I really do with this? So it's all about how do you contextualize it? And I think we just recently, last week actually, our over-the-counter product that's available on Amazon and you can buy on Stelo.com, it's now approved for children. It was previously only 18 and above. So now anybody who wants to drive a preventive nature, children can now use CGM. We have a lot of work to continue to evolve how children use CGM, but now it's available so they can start to better understand glucose.
Can I add something?
Yeah.
I think this makes me think about the fact that prevention is not very exciting for many people. Like if you tell somebody, eat better today, exercise more, eat more vegetables and less sugar so that you prevent prediabetes, it's not very convincing, right? I think prevention has a marketing issue. And so with Stelo, you solve a little bit of that problem because it's so exciting to see your glucose data. Yeah, I see you nodding. So I think that's why it's so powerful. When you see it, then you want to act on it, and it's almost its own engaging activity because your glucose responds in real time, and it's the inside of your body. Like, what better tool to have?
As we go to the next one, I will say, I used to say what you say a lot, which is we should have that wearable industry think about getting to people when they're younger, improving habits, and we've been measuring how that happens in college athletes and general college students and slowly moving to high school. I will mention the FDA. We had an FDA meeting about digital mental health technologies back in the fall. I don't know if anybody had listened to it. In that, there was one person that very strongly said, you are gamifying on the same screen that we are all worried about.
Yeah.
And so you have to think about that. So one of the things we've been talking about with the wearable industry now, and it would go for CGMs too, is do you build into the app, keep the CGM on, keep your wearable on, but you've been doing so great, take a couple of days break, don't check back. I'll alert you when it's time. And do we build the breaks into the system so that we're being healthy for our teens as we teach them to be healthy? So just wanted to throw that out there. We have a mic in someone's hand. Oh, up here.
I'm Elizabeth Cohen from the City University of New York. So thank you very much for this panel. And I just wanted to respond, Amy, to something that you said. We have a program running now where medical students, nursing students, PA students, pharmacy students, are all supervised, medical librarians, all supervised by clinicians, sit with people, and all they do is help them follow the instructions that they have been given. So I'm really hopeful that you can help me integrate this product into this up and running service, because people can get 6 appointments as long as they like. We go to them or they can come to us. And we really think that it's not inventing new things, but helping you all scale the things that you have. So if you could talk a little bit about how we might integrate this into that program, I would be so appreciative.
So let me also, Jake, I don't know if you have a response to that, but let me just say, Elizabeth Cohen is not just a distinguished professor at SUNY. She actually is the head of the science committee for all of us, which is one of the kind of best opportunities we have for gathering multi-omic and biologic data and eventually creating kind of predictive engines so that all the data we have now will feed in. So thank you for what you're doing. Jake, I gave you a minute to think too.
Yeah, no, there's a lot there. One of the things we're trying to do right now is just make sure that there is very good awareness of the clinical outcomes from CGM. Because for a long time, it's been kind of towards the more acute side of diabetes, type 1, insulin intensive. And we now have very substantial outcome data. Actually, some of the best outcome data we've ever produced is in patients that are not using insulin. So that is brand new data. We want to make sure everyone's aware of that. So getting the healthcare providers on board is really important. And then as we look to expand access to the technology, if you don't have coverage, there's still an out-of-pocket. But with coverage, it's now, most of our patients don't pay anything out of pocket. 30% pay zero. Most pay less than $40 a month. It's a really great place to get to, but we need to continue to drive coverage, and we'd be happy to talk about. Education is a big part of managing glucose, right? We've been talking about it all day, but also what the technology can do.
The Peterson Health Technology Institute did a report on looking at various forms of kind of measuring your glucose and their effect on outcomes. It's worth looking at. The world has changed since that. That was 3 years ago now, and outcomes are very different. But for anyone who's interested in whether or not monitoring means improving health care, there was a very loose connection. We had gone through a phase where everybody was measuring everything, and companies were judging themselves on, hey, I have more people on my thing. And actually no health was getting better. And so people like Jake at Dexcom, having Jesse out there talking about the importance of trusting yourself, now we're finally seeing outcomes move in a way that wasn't moved before. But it's a worthwhile report to look at. Let's do 2 more questions.
Hi, my name is Laura Jana, and I am a pediatrician that deals in early childhood, but also changing life trajectories. And I was struck by the fact that even 15, 20 years ago, people doing life coursework started saying that diabetes, heart disease, dementia, we're going to find all of them are diseases of childhood. We just didn't know what to look for. Yes. So I'm particularly interested. I was really glad that you asked your question. But I also think there's an opportunity aside, and I deal with young children. And yes, people have done Fitbits and all sorts of things with young children looking at activity. I don't know that it's just for you, and this is a question for you, Jake, is that it's not just sticking Stello on a young child's arm. That could be very challenging to keep on and to use. But also, as you do your research, we don't know what normal is, what spikes children have, what patterns we might recognize. I deal in the let's get kids to eat healthy when it's a healthy habit early, as opposed to having combat it when they're teenagers. But I'm really interested in what you are doing or might be able to do when you're doing your research to start looking for those earlier markers of patterns in glucose that might predict future risk.
Well, when you think about adolescent population and even young kids, we're seeing a lot more type 2 diabetes, and a lot of this is education around nutrition and the CGM. I think there's an opportunity for any child to wear a CGM and better understand what the food they're eating does to their glucose. And we don't have a lot of CGM data in children that don't have diabetes. We have lots in children with diabetes, type 1. But even the type 2 diabetes, we don't have very much. We know that the incident rates are increasing. And so we need to generate more data, but there is an opportunity to really get after the nutrition of children in this country that I think CGM is an important tool to show the impact and engage the children with it. And still lots of work to do there, though.
Jesse, thoughts about pediatric age, younger people, engagement?
No, that's not my expertise.
Okay. It's not my expertise either. I'll tell you a quick story, and then maybe we'll end. My younger daughter is all about climate, so I do a lot of AI work, and she keeps reminding me, how many gallons of water is that, Mom? Right? And so she would be in the other tent this morning over there. My older daughter, firstborn child of the same gender, those of you who, raise your hand if you have one of those, firstborn, yeah, okay, pushes back. And so I used to walk around talking about eat the rainbow. And I thought that was like a really clever way to remind people all these different, types. And I had probably learned that in my younger years. And one day, when she was on that prime, lovely teenager, she kind of whispered over to me as I was on a Zoom, right? She leans in the room and she goes, Fruit Loops. And I was like, are you kidding me? But what it made me realize is I was not actually speaking to Gen Z or millennials, right? I wasn't actually learning their language. I wasn't speaking to them. So maybe as my last comment, since we've just hit 0, is I think we're coming to the fact that patients need to be empowered, that glucose sensing is a great opportunity for us, that we're trying to increase its access and education about it. But while we do it, just increasing education about glucose, feeling your own body, watching if I had carbs this morning, how do I feel versus this morning's eggs? But we have to think about those who are younger than us in the next generation if we really want to do prevention. So I think we have to reach them where they are. And I see that starting to happen here, but we can't say that TikTok is not a way to reach them. We can't say that social media doesn't work. We can say that there are dangers to certain things, but it works. We have to reach them where they are and give them the kind of things we want them to consume. And so I would just encourage everybody here to also remember that. We're not going to get rid of heart disease, diabetes, et cetera, if we only aim at the older generation, but we have to meet people where they are. Thank you all, and thank you, Jake and Jesse.